Hello and welcome to EMS Research with Professor Bram, where we talk about the research-related issues that matter to those who work in emergency medical services. Today, we'll be talking about protecting the brain during CPR. Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I'm your host, Bram Duffy. I'm a full-time paramedic on the street, like many of you. I also have an appointment as a research fellow with the Institute for Social Innovation at Fielding Graduate University, and I'm an assistant professor of communication at Kennesaw State University. I actually have a research study open now for first responders, so if you don't mind being interviewed by me, then go to my website and check it out, www.professorbram.com. It's professorbram.com. You just click on the current research tab to apply. The other thing to share before we get started, I have written 2 different books on communication. And the most recent book was just released called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can find a link to the book below. Also, for sure, hang out to the end and I'll tell you more about it. I'd like to have everyone join me in welcoming Ashley Buie, who is a paramedic who works in Northampton County, North Carolina, and teaches at Rowan Community College. She just finished her flight paramedic certification and recently wrote an article in JEMS that caught my attention. And so we're really thrilled to have Ashley on the show today. It's going to be fun talking to her about CPR, but tell me more about yourself. Did I miss anything?
That's the short and sweet version of it. I got started in EMS very young, just like you. So I initially took EMT class when I was 16 in high school. And it has been a wild ride since then. And here I am practicing as a paramedic, and I have my flight paramedic certification.
So that's how you got interested in EMS, was through the high school program?
Yes, I was actually initially taking it as like a way to pad my resume to get into nursing school, but I fell in love with EMS along the way and decided to stick with it. So.
Awesome stuff. So we want to talk together about this article that you wrote called Neuroprotective CPR that you wrote in the Journal of Emergency Medical Services. And I just want to summarize some of this because it's really exciting. Recent studies have shown that there are 3 key elements that we can use to improve the chances of cardiac arrest patients surviving with their brain function intact. And so these elements include raising the head and torso, using active compression, decompression, the ACD CPR, and using the impedance threshold device. All these techniques can help improve blood flow to the brain and heart during cardiac arrest. So in practice, this means keeping the patient's head up and the pressure low. The method has been shown in animal models to increase blood flow to the brain and improve survival rates. So raising the head and chest or head up position can significantly reduce pressure inside the skull while improving blood flow to the brain in patients with severe traumatic brain injuries. So the pressure inside the body was monitored continuously using a technique called the Selinger technique, and a probe was used to monitor blood flow in the carotid artery. A gauge was also inserted into the brain after cranial surgery to monitor pressure within the skull. And interestingly, when patients were positioned with their head and torso raised, these resuscitation rates improved significantly. So over the next 2 years, these rates doubled on average, with improvements seen across all subgroups. Survival rates remained stable at around 35 to 40%. The impedance threshold device is a small device attached to the end of the breathing tube. It enhances CPR by increasing the negative pressure inside the chest during the decompression phase of the CPR. And this leads to an increased blood flow to the heart, which in turn increases cardiac output and blood pressure in patients with low blood pressure or cardiac arrest. The device has been shown to increase pressures in the heart and brain nearly 4 times compared to just standard CPR. The other thing is that studies have shown that survival rates 24 hours after cardiac arrest were significantly higher in patients treated with the active impedance threshold device, 27% compared to those treated with a sham device, which were like 11%. So using the combination of head and torso elevation, active compression, decompression CPR, and the impedance threshold device really is shown to significantly improve survival rates and brain function in cardiac arrest patients. And this is a promising development in our field for cardiac arrest patients. And so I just want to ask you about how you came to write this and tell me about your CPR experiences. I'm sure all this has been stuff that's affected your article.
Sure. So since I got an EMS, I've worked countless cardiac arrests. But as my experience grew and I became more interested in cardiac arrest, the question arose of what happens afterwards, because that's not something that we see or hear from in EMS. Our care pretty much ends when we transfer care or the patient ultimately dies in the field. Um, so it became very important to me of understanding the quality of my interventions that I'm doing on my patients and how it affects their life in the long run. And I came across this concept actually during the critical care paramedic class that I took, and I was tasked with writing a research paper on anything that I wanted to know. And I wanted to learn more about this. So I decided to do my research paper on that. And my instructor kind of encouraged me to turn this into an article and have it published. So that's how this all came about. And I just think it's very promising research. And I really care about the outcome of my patients. So I would love to see this research come to light, more broadly so that we can see the effects of it.
Okay, so when I have used the impedance threshold device for my CPR patients, I just have to share, like in practical sense, when I use it, when this thing is in process, I know that I just have to remember to get the thing off once I get ROSC, right? That's
Yes.
because we don't want those pressures to be the same. And so it's little things like that are different about how we're going about this process because, well, this is new. So besides just that, besides taking it off as soon as you get Ross, tell me, how does the CPR work for you in practical sense? I know a lot of folks are familiar with standard ACLS, but now when we add this in, what's it like?
Yeah, so one of the big things that I've noticed in my system, we use the impedance threshold device, and I had never used it prior. And my first cardiac arrest at my system, I forgot to put the ITD on. And then once I did, I noticed an increase in the end tidal CO2 of the patient, which was very intriguing to me because that just shows you that the perfusion is so much better with that device on.
Yeah.
And it's just pretty outstanding that such a tiny device that just goes onto the end of the ET tube that any level provider can use can add that much impact on the way that our CPR is being performed.
And so for those who haven't got to use it before, it's like a little plastic hard bulb that you pull a trigger on that starts at light. So a light blinks, and that's supposed to represent the time when you squeeze the bag. Or at least that's what I tell the firefighters that are working with me so they don't overventilate. And so it adds a little bit of weight to the end of the ET tube. So it's like something to think about. But basically it pops on the end. And the thing that I understood from my training with it was that it needs to be right up against the ET tube, right? So if we have an entitled CO2 detector, that's great and all, but that's going to go later in the sequence, right?
Correct. Yes.
So that the pressure is directly on. So tell me more about how this head up position would work. So are we talking about doing CPR on a patient with their head elevated, or tell me more about, like, in practical sense, how it would all come together?
So the device that has been manufactured is called the Eligard device, which is what I was kind of speaking about in my article. And this device actually gradually elevates the head over about a 5 minute period. So the head is elevated approximately 22 centimeters and thorax about 9 centimeters over that time period. And basically, how this works is the idea is that when we're doing our traditional supine CPR, we're not getting ample outward blood flow from the brain. So every time we're doing a compression on the chest and we're sending blood up to the brain, it's like meeting resistance and almost causing like a concussion to the brain during that time frame. So, as the head and thorax are being elevated, we're essentially using gravity to assist with the outward blood flow from the brain so that we're creating more space for inward blood flow. And by doing that, we're seeing a decrease in intracranial pressure and an increase in cerebral perfusion pressure by elevating the head and thorax.
That's exciting. And so when I look at the article, it shows um, the device, and it's basically connected to a Lucas system, right?
Yes.
And so the interesting thing about Lucas devices, from my experience, has been that I'm just a big fan. Like, I've used them a lot. I have saved people's lives using them. And when I get ROSC, I really attribute it to that machine. I am super big fan of these Lucas devices. When I look at the research studies on Lucas devices, they actually, I don't know if you know this, but they actually, from what I've seen, they don't necessarily show that they have better outcomes than traditional CPR. And it just blows my mind, because in practical sense, I am here to tell you, I see it, because I don't know about all the different components of that. But now when I can see that we're adding Lucas to this elevation technique with the impedance threshold device to like do a whole system, I just can't imagine much. Based on what we know about medicine today, I can't imagine much more of ideal situation. And so I I wonder about the um, the comparison of just straight up the Lucas device with and without this. I don't think that that's been done yet, but that's where we're at. Are there a lot of these devices where you're at?
The Eligard device or the Lucas?
Both. I was just, yeah.
Most agencies in my surrounding area do have the Lucas. I don't know of any agencies that have the Eligard. However, my agency just purchased the Eligard device. We just have to go through our initial training before we roll it out in the field.
Okay, so that's really exciting. And based on that, I want to invite you to come back on the show later and talk about it once you've had even more experience, because I can tell this is something that has probably got your whole department excited about what can be done, to help these folks. And so, um, tell me about the difference between the sham device uh, and the impedance threshold device. I want to make sure I'm clear on those differences.
Sure. So the impedance threshold device, you kind of summarized it a little bit in the beginning, but it's a device that creates negative intrathoracic pressure. So the way that I like to look at it, it's essentially doing the opposite of what a PEEP valve would do, right? So it is creating almost a vacuum in the chest, and that vacuum is increasing our coronary blood flow, and it is increasing our systemic blood pressure in the long run, like when it's being used. And it should be that light that blinks when we squeeze it should be during the decompression phase of CPR. So when we're not putting any outward pressure on the chest. The sham device used in these looks exactly like the impedance threshold device, but it does not cause the negative pressure. So it's essentially a device that is used to blind the researchers, almost like a placebo medication during like medication trials, so that the researcher does not know exactly what device that they're using, so that they're not biased to the research.
Now I understand. Okay, so this was just to help with the research study so that they could tell the difference in the outcome, or the numbers, the difference with it and without it. Right.
Exactly. Yes.
Awesome. Okay. So have we found any drawbacks or challenges that people face when looking at using this system yet?
Anecdotally, what I believe the biggest challenge is going to be is I don't want this system to take away from what is most important, and that is early recognition and initiation of CPR and timely defibrillation. It's very easy when we add new, fun, shiny toys and tools to our toolbox to get kind of tunnel vision on that and not focus on what's most important. So, to anybody who is new to this system and these devices, the most important thing is still going to be CPR, starting early CPR, and not reducing our chest compression fraction, because we still want our chest compression fraction to be 80% or above, right? I mean, we learned that in just basic AHA CPR. So practicing with this device and getting all of the maneuvers down as a team so that you're adequately placing the patient on it and not reducing that chest compression fraction is what's going to be most important.
Yeah, and I've seen that. I've seen some of the common mistakes I've seen is like putting a patient that's too large on it from the start, right?
Sure.
So, these devices have there's only so large of a patient that you can put on there. And so if you just really wish beyond all wishes that you could squeeze a patient in there, it's not going to work. It'll pop off. These Lucas systems aren't made for that. And so I just want to mention, I've been in situations where, like I want it to work for me, but it was misjudged and I should not have even tried it because it didn't fit. And the only problem with that is that there were seconds there where chest compressions were not being delivered that, could have been right during the time we had to roll the patient on the device. And so like what you're saying, I think is totally true. The downside to this is that we have to be practiced as a team so that we don't stop chest compressions. And I don't know if you've seen it, but I have ingrained in my mind that American Heart Association video that shows chest compressions and the pressure that builds in the chest as you continue the thoracic pressures that are allowed to occur in the chest during the compressions versus when you stop, right? And then you have to allow the buildup all over again. So
Yeah, so it
any
takes
kind of stop.
about 10 seconds for that pressure to build up once CPR is started, but it only takes about 3 seconds for you to lose that pressure. So that's something to like keep in mind of how important those chest compressions are.
That is so powerful. Yes. And so back to practical sense, I'm imagining doing this process. So we put are doing our regular CPR things, but now we're putting the patient on the Lucas, and the Lucas will automatically do head elevation and stuff. And we know that the impedance threshold device goes on the tube. And then when we hit ROSC, the impedance threshold device goes off, right? We take that off. But what about the other system? Are we going to hit a button that says we have ROSC and then it deflates so that the head's flat again? We don't
That
know.
that is a question I do not have an answer to.
I'm
Yeah,
so excited for you that this is all coming. So, um, I I just know that if based on what I've seen with Lucas, and we add this kind of stuff, it just makes me super excited. And the next thing you know, we're going to be doing more and more in the field, and we're here at it. So thank you for joining me today. It's been great being able to talk about this stuff. And so I look forward to inviting you back to hear more about your hands-on experience with the same machine.
of course, I'd love to. Thank you so much for having me.
I want to also invite you to check out my latest book I co-authored with Four Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis. So I just want to invite you to check it out because we introduce a method for communicating with patients on the scene of an emergency that takes advantage of some of the properties found in hypnosis. This book works to change the way we approach and interact with any kind of emergency patient in acute distress because it's going to help you be a better practitioner and use communication as a healing tool. Right now, there's just not a lot of training in how to talk to your patient. And if you've been stuck with a patient for any period of time and you need to have a conversation, it's awesome to be able to have a healing conversation. This book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow the link below to find it, or you can find it literally almost anywhere you type in the name or my name. I had a friend that mailed me a book and wanted an autograph. Don't mail me a bunch of books. Just let me know that you want an autograph for the book, and I'll be happy to send you over a sticker. I have some stickers made that are pretty awesome that I'll send you that you could put in the cover.
Hi, I'm Will Chaplow from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com and also published through JEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth a field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get them for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon. Thanks.
The other thing before we close that I want to share is that I'm doing a research project related to first responders who live in the United States. And I could really use your help if you don't mind being interviewed over a video call. So go to my website, fill out the form that's at professorbram.com, professorbram.com. And thank you again for listening. I look forward to sharing more insights with you in this next episode. If you enjoy EMS research, please tell your friends, like, share, and subscribe to help others get the message. And then stay tuned for the credits at the end so you can see the research articles that we talked about in today's episode.